Good
Okay,
morning, everyone.
all set.
A very warm
Uh,
welcome to all of you for yet another academic session by KCIAPM School of Pathology, a forum dedicated for sharing knowledge and fostering diagnostic excellence among budding pathologists. Today's topic is truly an exciting one, a pattern-based diagnostic inflammatory dermatosis, an algorithmic approach. Dermatopathology, as we all know, often presents as a diagnostic puzzle. This session will help us understand how a structured, step-by-step approach to can make the process clear and logical. And it is my pleasure to introduce our distinguished speaker for the day, Dr. Thejasvi Krishnamurthy, Professor, Department of Pathology, Kempegowda Institute of Medical Sciences, Bengaluru. Dr. Thejasvi has been an integral part of the KIMS for the past 20 years, contributing immensely to teaching, diagnostic, and academic mentorship. He also serves as consultant pathologist at Padma Shri Diagnostics, Bengaluru, and has been an NABL assessor since 2011, upholding the highest standards for laboratory quality and accreditation. He also holds an MD pathology degree and FRGHS fellowship in dermatopathology from Bangalore Medical College. With around 20 publications, both international and national journals, Dr. Thejasvi has a significant academic contributions to the field. He currently is the treasurer of Karnataka chapter IAPM and has held this role since 2018. Among many of his accolades, he is the winner of the Capcom Quest 2019 and runner-up in 2018, highlighting his continued enthusiasm for academic excellence. In today's talk, Dr. Tejasvi will take us through the art and science of identifying these histopathological patterns and taking a step-by-step approach to diagnosing disease. And over to you, sir.
okay, thank you very much. So this is pattern-based diagnosis of inflammatory dermatosis. So this is an algorithmic approach. Just not to waste time, we'll go to the next slide. So what is the purpose of this topic? So purpose of this topic is to categorize or narrow down the differentials of inflammatory dermatosis based on histomorphology, even in the absence of appropriate clinical details. Okay, so even in sometimes you will lack clinical details, sometimes the history is incomplete. So in spite of it, you would like to narrow down your diagnosis. This probably would help you. Who is the target of people who actually should join and should keenly listen? Anybody can join for that matter, but who should? This is purely for beginners who nurture an interest in reporting dermatopathology slides. Okay, so moving on. So this is a small question. In what form does the largest organ of the body meet a pathologist in a histopathology lab? So everybody is aware that it's a punch biopsy. So this punch is done in so many sizes actually. You can maximum till you can do an 6 mm or 8 mm punch also. So from 1 mm to 8 mm you can do a punch, and usually the depth is desirable. Say for example, if you want the subcutaneous, you can go deeper, and depends on the site of the biopsy as well, where you are going. So the depth is decided on the site of the biopsy, and if you want to include the subcutaneous adipose tissue, the depth is more. Okay, so it's usually
Sorry to interrupt, sir. Your voices are not audible.
now this is not very where skin is superficial and where you need not have to damage the skin, like example face, forehead, scalp, etc., etc. Now there is and another thing. It comes in form of excision biopsies where you require a margin. So there is some neoplastic lesion and require a margin. This is excision biopsy, and you have these incisional biopsies where you require to compare the normal skin to the lesion. So incisional biopsy, excision biopsy, shave biopsy, and punch biopsy. Punch biopsy being the commonest. Okay. So most of you would have seen all these in your practice, and people who are new would see it more often. Now, so when you've done a biopsy, this is what you see in normal or for a normal anatomy of skin. There is keratin layer, there are dermal papillae, then there is dense irregular connective tissue, then there's dermis, then hypodermis and adipose tissue. The epidermis and dermis you all are aware of. Then there is, if you go into the epidermis, that is stratum corneum, stratum granulosum, stratum spinosum, the stratum basal, and the dermal papillae is visible in this meal. So the stratum granulosum is the one that easily you identify with the presence of granular, the keratohyalin granules, and the usual basket weave type of keratosis what you see is stratum corneum. And the adnexal structures, the most important adnexal structures, the sebaceous glands, the eccrine sweat glands, the hair follicle, hair shaft, erector pili muscle, and the other things. So the neurovascular bundles, that is neurovascular bundles also that I think I've missed out on this picture. Hair shaft, sebaceous glands, and erector pili muscle are there. And this is the vascular supply. So usually the vascular supply is a lot of anastomosis. There's a deep vascular plexus, superficial vascular plexus, and there is vascular anastomosis in the around the pilosebaceous units as well. Okay. So moving on, few terminologies for the beginners you should be aware of before, because we'll be using that in the course of this session. So one is hyperkeratosis. You saw the keratin layer there. So whenever there is thickened, whenever the corneal layer is thickened, or there is, we call it hyperkeratosis. I'm not in the subsequent presentation, in the subsequent time or subsequent slides, you'll be seeing the what does actually exactly pictorially or in the biopsy, how do you see hyperkeratosis. The next one is acanthosis, is epidermis hyperplasia. Hyperplasia of the epidermis is called as acanthosis. Parakeratosis is retention of nuclei. Parakeratosis is retention of nuclei in the keratin layer. When you see hyperkeratosis, you usually look into the keratin layer and under the 10x or 40x, whether you're seeing nuclei in the keratin layer. That is called as parakeratosis. Now, if the hyperkeratosis is present and it is compact without any nuclei, then it is called as orthokeratosis. We have some more like spongiosis, where we have intracellular edema. Intracellular edema, that is a cell, intercellular bridges are clearly visible and there is space in between or light in between the intercellular bridges of the keratinocytes, then you call it spongiosis. Then we have hypergranulosis. Hypergranulosis is when the granular layer is thickened. So usually one or two layers are visible. If you see it very easily and it is more than 2 or 3 layers, then we call it as hypergranulosis. Then we also have this commonly used terminology of interface inflammation. What is this interface inflammation? It is nothing but inflammation in the dermoepidermal junction. Interface inflammation is nothing but inflammation in the dermoepidermal junction. And we commonly use this term also, especially when we go towards lichen planus and other disorders. Basal cell vacuolar degeneration. This is nothing but hydropic degeneration of the basal cells, where you see empty appearing cytoplasm. Empty appearing cytoplasm, vacuolated cytoplasm, okay, of the basal cells because of hydropic degeneration. We also see vesicles or bulla. We can see spongiosis, which becomes exaggerated and form vesicles or bulla, which is clinically visible as well as blistering diseases. Then we have leukocytoclasis. We commonly use this term around the blood vessels whenever we describe vasculopathies or vasculitis, where there is fragmentation or karyorrhexis of the neutrophil nuclei around the blood vessels. One last term is the necrobiosis. Necrobiosis, when do we use? We use necrobiosis whenever there is degeneration or necrosis of this collagen. Usually appears like basophilic, or there is exaggerated eosinophilia of the collagen, or there is swollen collagen. We usually call it as necrobiosis, which is surrounded by histiocytes, etc. We will encounter this in our subsequent slides. Okay. So now the roadmap to the roadmap approach to inflammatory dermatosis. It is basically, as we have been saying, as the topic also says, it is pattern based. As the topic also says, it is pattern based, and let's see how to move. So basically, if you read standard textbooks, there are 4 patterns of inflammation. 4 patterns of inflammation, which is based on inflammatory cells within the skin. So the basis on the inflammatory cells and the basis of distribution of inflammatory cells within the skin. So what is the basis of the distribution of inflammatory cells? What are these patterns? So superficial perivascular inflammation. So it is very simple actually. It's not so complicated because it's a punch biopsy and you're seeing something deep, something superficial. So superficial perivascular inflammation, superficial and deep, when you see both superficial and deep dermal inflammation, folliculitis and perifolliculitis. If the inflammation is around the hair follicles, then perifolliculitis and folliculitis and panniculitis. Okay, the panniculitis is a subcutaneous adipose tissue. It is inflamed. You call it panniculitis. So these are the patterns of inflammation described in standard textbooks, and the basis is their distribution in the dermal inflammation. Okay, in the dermis, basically in the dermis. Now, With this, we also have this tissue reaction patterns. Tissue reaction patterns are separate entities. So groups of diseases rather than telling entities, it is groups of diseases wherein we have lichenoid, we have psoriasiform like that. So lichenoid reaction pattern. So these are tissue reaction patterns, how the tissue also responds with for the inflammation. So, lichenoid reaction pattern is characterized by basal cell damage and interface inflammation. Psoriasiform reaction pattern. So, regular epidermal hyperplasia, if you see, it is called a psoriasiform reaction pattern. And spongiotic reaction pattern, intraepidermal intracellular edema. That we already told you what is spongiosis. Spongiotic reaction pattern. There are a group of diseases which can be categorized into spongiotic reaction pattern. This is nothing but because of the intraepidermal intracellular edema we have been seeing. Vesiculobullous reaction pattern is blistering within or beneath the epidermis. That is, whenever you see blisters within the epidermis or beneath the epidermis, we actually categorize this under vesiculobullous reaction pattern. Then we have granulomatous reaction pattern where we see granulomas, basically chronic granulomatous inflammation. We'll be seeing granulomas and the distribution of the granulomas. Based on that, we have to narrow down our differentials. Then we finally have the vasculopathic reaction pattern. Vasculopathic reaction pattern, pathological changes in cutaneous blood vessels. So whenever we see these any changes around the blood vessels or any pathological changes, these we see in the vasculopathic reaction pattern. So we now have patterns of inflammation and tissue reaction patterns, two things which we have to look at, and the tissue reaction patterns are labeled based on a group of diseases that you should remember based on these changes of the skin. Okay, maybe it is basal cell damage or interface inflammation. There is regular epidermal hyperplasia, or there is intracellular edema, or blistering or bulla, that is vesiculobullous reaction pattern, or you're seeing granulomas, or there is changes around the blood vessels, cutaneous blood, or changes involving the blood vessels as well. That is vasculopathic reaction pattern. Now, so we have to create or devise an algorithmic approach to inflammatory dermatosis. We have two things in hand, that is the inflammatory patterns as well as the tissue reaction patterns. So how to go about? We have two things and devise an algorithm where we can diagnose or narrow down our differentials. So this involves three steps, very simple three steps. One is evaluate the pattern of inflammation that we just now listed, that is superficial nape and panniculitis or perifolliculitis. Correlate with the tissue reaction pattern. So lichenoid, psoriasiform, etc., correlate with that and arrive at a diagnosis. Doesn't it sound simple? Okay. Evaluate the pattern of inflammation, correlate the tissue reaction pattern, arrive at a diagnosis. Of course, there will be associated features which will be highlighting along with this associated features, which we also keep in mind, which helps us narrow down or pinpoint a single tissue diagnosis. Okay. Okay. Now coming on to the first reaction pattern, that is the lichenoid. We'll go these along these reaction patterns and we will see what is the patterns of inflammation in this, and finally we can deduce an algorithm. Okay, so we will just run through histological pictures of few variants or prototype variants of lichenoid reaction pattern. Later on we will see how we can apply the algorithm. First of all, coming to the lichenoid reaction pattern. So basically what we are seeing here, we are seeing hyperkeratosis. We are seeing a prominent granular layer. There is a band-like infiltrate in the dermoepidermal, band-like infiltrate in the dermoepidermal junction, which are basically lymphocytes. Let's see, because it's a low power image, you're not able to see closer, but I'm just telling you, it is just a band of lymphocytes which just are masking the dermoepidermal junction. So this is a case of lichen planus. So this is a characteristic feature everybody would have taught you, the reporting pathologist would have taught you. This is a case of lymphocyte when you're seeing band-like inflammation in the dermoepidermal junction, or what we call as interface inflammation. So this is a case of lichen planus. If you go closer, you can see that hydropic or basal cell vacuolar degeneration as well along the basal line, hydropic degeneration of the basal cells with the prominent granular layer and the keratin layer as well. Then again, if we observe along the interface, there is a lot of the band-like inflammatory infiltrate is highlighted. You also can see the keratin layer on top and the thickened granular layer. Now, if you observe closely, what are we seeing here? We are seeing something that is encircled. These are nothing but necrotic keratinocytes also, or apoptotic keratinocytes. We usually call them as apoptotic keratinocytes, and also called as sebaceous bodies. So these sebaceous bodies are the one, because of the continuous damage, they undergo apoptosis, and only the cytoplasm or epignotic nuclei is visible in the dermoepidermal junction. The basal cells usually undergo apoptosis and give rise to what we call as sebaceous bodies. Now you're seeing something else here. These band-like inflammation with, there is something, the arrow is pointing, and there is the lichenoid or the inflammatory infiltrate is going above, little above, closer to the granular layer, close to the top of the epidermis, where we see this specifically in lichenoid drug reactions. The lichenoid response is exaggerated. That is, it is going closer to the glandular layer. So exaggerated lichenoid response, if you see, then you will be seeing in drug reaction. But you have something additional to look here. You have to look for eosinophils. It's the dermal inflammation, where you're seeing the band like lymphocyte infiltrate, or lower down, or around the blood vessels, or closer to the epidermis. You have to see eosinophils. You can identify these eosinophils by their cytoplasm and the bilobe nucleus. Okay, so these eosinophils, along with an exaggerated lichenoid response, that is exaggerated interface dermatitis, where the inflammation is going high up, close to the granular layer, then you can identify this as drug-induced lichenoid change. Now going on, what are you seeing here? There is epidermis over here. There is the end of the epidermis over here. Just a minute, I'll switch on the pointer. Okay. You're seeing the end of the epidermis here, but the inflammation over here, that is in the under square, is rich in some kind of cells. They're eccentrically placed nuclei. These are all plasma cells. These are all placed. Where do you expect to see the lichenoid response? You saw eosinophils previously. Here you are seeing plasma cells. Then this is nothing but secondary syphilis. So if you're seeing a lichenoid and a plasma cell rich infiltrate, think of secondary syphilis. Of course, you have to correlate with VDRL, site of the lesion, presentation, etc., etc. Clinical details do play an important role here. Then we have this something else. Here's something we have just trying to a rectangular, under the rectangular box, we try to categorize what is important. Here you're seeing a typical lichenoid reaction or interface inflammation just in the elongated rete ridges, just at the edge of the elongated rete. But there is nothing here. Here it is clean, okay, or clear, rather clear than whatever you. So there is a difference between this and the papillary dermis. Here is clear, whereas there is lichenoid reaction pattern, or what we call as interface inflammation here. See here in the elongated. This is characteristic with the hyperkeratosis, prominent granular, etc. This is characteristic feature of hypertrophic lichen planus. So this is a characteristic feature of hypertrophic lichen planus, that when you see the inflammatory response or the interface inflammation is restricted to the basal layer, okay, base or the elongated rete ridges only. Now, what are we seeing here? Similar interface inflammation close to the, this is a hair follicle, okay, this is a hair follicle, okay, close to the hair follicle or close to the isthmus of the hair follicle. So what is this? This is a case of lichen planopilaris. So see, lichen planopilaris can be perifollicular inflammation or close to the isthmus. Okay, so this, we are not delving or dwelling into the pathology, pathogenesis, etc., etc., but we are trying to morphologically categorize these diseases or the prototype lichen planus and its variants, and trying to build an algorithm. So now we are seeing something else here. There is an elongated rete, very typically encasing the lichenoid reaction or the interface inflammation here, with somewhat destroying the epidermis over here. So this inflammation infiltrate with few histiocytes. You can actually see, if you go closer, you can see histiocytes. So this is a typical feature of lichenitis. So this is a typical feature of lichenitis, where you can also see histiocytes along with interface inflammation in the dermoepidermal junction, with what we call as elongated rete encasing the. This is called as clock clutching pattern of clock clutching pattern with lichenoid infiltrate. Then we have another entity very closely associated, morphologically, histologically very close to lichenitis, is lichen striatus, where we'll be seeing similar lichenoid response between the elongated rete in the papillary dermis, where we'll be seeing, but they can alternate in between 2 or 3 papillae, and alternate in between 2 papillae and similar lichenoid reactions. But there is something additional you have to look at in this, and this is periadnexal or pericrine inflammation. Pericrine inflammation also is a feature of, you should and must try and see this to diagnose a case of lichen striatus. Here also clinical details become important because these are linear lichen striatus, are linear lesions, and they are distributed along the dermatomes. Okay, they are distributed along the dermatomes. So clinical details, wherever it is important, I'll be reiterating, and just carefully you can note down. So lichen striatus, it will be in the papillary dermis and periocrine. Lichen nitidus, papillary dermis restricted to one or two. Here alternating papillary dermis, but here periocrine will be there. There you can see histiocytes. Remember that. Okay. Now what are we seeing here? There is flattening of rete, and something that is we don't have to search for is some brown pigment incontinence. Pigment incontinence is seen over here. So this pigment incontinence, along with quiet, very silent dermis. There is not much of inflammatory activity also, but the rete have been flattened. This is a common seen in ashes dermatosis, or what we call as erythromatous chromicum persistens. Okay, if the inflammation is more, or the activity you're seeing similar to lichen planus, that is there is basal cell vacuolar degeneration or lymphocytic infiltrate damage to the basal cells, you can call it lichen planus pigmentosus also, if with pigment incontinence. Okay, another picture for ashes dermatosis, little closer view. Now, there is something else you're seeing here. Again, flattened rete, little bit basement membrane collagenization here. Okay, then pigment incontinence and basal cell vacuolar degeneration as well, where basal cell vacuolar degeneration is prominent. And can you see this collagen thickened basement membrane over here with pigment incontinence? What this could be with little amount of hyperkeratosis and prominent glandular. This is a case of DLE, or discoid lupus erythematosus. Here you can also see the dermal collagen. It's sort of degenerated, that is somewhat hazy, somewhat smudgy looking. So this is basically because of mucoid degeneration of the collagen, and this is algae lutein, same where you can see the algae blue positivity of the collagen or mucoid degeneration. So, okay, depicting the mucoid degeneration. Now, this is case of discoid lupus erythematosus with algae blue stain, algae blue positivity. Now, there is another case here. Little epidermal thickening is there. Little activity you are seeing in the interface with basal cell vacuolar degeneration. There is inflammation, but the inflammation is extending throughout. There is interstitial inflammation here also, and here there is some inflammation around the superficial vascular plexus and around the adnexal structures here. So, what this could be? This is another feature where there is activity high, discoid lupus erythematosus. So discoid lupus erythematosus can be very active. In the active phase, if you do a biopsy, then you can encounter this also. You can still look for acanthosis and basal cell vacuolar degeneration, interstitial inflammation, as well as periadnexal inflammation also. Perivascular and periadnexal inflammation with interstitial inflammation can be discoid lupus erythematosus also. That you should keep in mind. Apart from mucin degeneration, epidermal atrophy, basement membrane thickening, all these follicular plugging, so many features are there to diagnose discoid lupus erythematosus. But it can have this form also. You should be aware. So what is this now? So this is where you're seeing the epidermis is not at all existent close to the dermis. There is so much amount of destruction in the epidermis, and if you see, if it's difficult to make out nuclei over here in the lower part of the epidermis. Okay, lower part of the epidermis difficult to make out nuclei. It's a necrotic epidermis. It's almost lifted up and it is exaggerated. It's almost forming a bulla. So what this could be? This is erythema multiforme. This is drug induced, and you'll be seeing lot. If you go closer, you'll be seeing lot of these apoptotic keratinocytes very close to the granular layer throughout the epidermis, in the mid epidermis, etc., etc. You'll be seeing close to the that will be a clue for you. And usually you'll also be seeing these apoptotic keratinocytes being surrounded by lymphocytes, which is also called as satellite necrosis. So this also is a feature of erythema multiforme. So in another picture of erythema multiforme forming a bull. Okay, the epidermis is completely peeled off and it is turned upside down. So it's a section that we tried to take a picture because you can get these kind of slides also where the epidermis is turned upside down, but you have to observe the epidermis where there is necrosis of the epidermis. So now our most important job. So I've seen few of the lesions of lichenoid reaction pattern, and we will have to summarize in the form of an algorithm. We will have to summarize in the form of an algorithm. How to go about doing this? Now carefully listen, and all your attention to this. So when you call lichenoid reaction pattern, inflammation at dermoepidermal junction with necrotic keratinocytes. So you're seeing this, you can call it as lichenoid reaction pattern. So lichenoid reaction pattern can be Now, clinically, this is multiple and solitary, whether the lesion is solitary or multiple. So here again, little clinical details become important, whether the lesions are multiple or solitary. If it's solitary, then it can be only three things: lichenoid keratosis, actinic keratosis, or regressing lentigo maligna. Okay, lichenoid keratosis, actinic keratosis, and regressing lentigo maligna. If they are multiple, then we have a job at our hands. Okay, so multiple, it is dense, diffuse, superficial, or dense, diffuse, deep. So if it is dense, diffuse, superficial, are we seeing necrotic keratinocytes limited to the interface? If yes, then it is lichen planus. So are we seeing exaggerated and higher up inflammation? That is, we saw a picture also. Remember, exaggerated and higher up, and that is close to the granular layer. Then it is eosinophils. Then are we seeing eosinophils? Then it is drug induced. So eosinophils with exaggerated lichenoid response, it is drug induced lichenoid change. Then if are you seeing exaggerated lichenoid response and it is lymphocytes, then it is graft versus host disease. Graft versus host disease is also very common. You will see rashes in graft versus host disease. So rashes with lymphocyte predominant inflammation and exaggerated lichenoid response close to the granular. That is, inflammation will be in the interface, will be going up close to the granular layer. So it is graft versus host disease. Then you have dense, diffuse, deep inflammation. With lymphocyte predominant, then it's discoid lupus erythematosus. We saw that. So dense, diffuse, and deep. So inflammation is from extending from superficial to deep. Then if you're seeing dense, diffuse, deep, and you're seeing plasma cells, you can take a guess. It is secondary syphilis. We all saw the lesion also. It is secondary syphilis. And then going further, dense patchy inflammation. So we saw dense, diffuse, superficial, dense, diffuse, deep. Now we're coming to dense patchy inflammation. Dense patchy inflammation in the papillary dermis with histiocytes, you all know already, it is lichen nitidus. And dense patchy inflammation, papillary dermis and pericrine involvement, it is lichen striatus. Okay, so then we have dense patchy inflammation, predominantly tip of the rete, it is hypertrophic lichen planus. Okay, dense patchy papillary dermis with histiocytes, lichen nitidus. Dense patchy papillary dermis and pericrine involvement, it is lichen striatus. Predominantly tip of the rete, it is hypertrophic lichen planus. Now, going further, mild and superficial. So we finish with the dense category. We go on to mild and superficial. There are two things here: with pigment incontinence and necrotic epidermis and exaggerated necrotic keratinocytes. With pigment incontinence, then it is with significant residual inflammation, you have lichen planus pigmentosus. So you're able to recognize the inflammation here. If you're able to recognize the inflammation, then it is lichen planus pigmentosus. Then if it is inflammation is minimal, or you have to look for a search for the inflammatory infiltrate, then it is ashy dermatosis. So with pigment dermatitis, significant residual inflammation, lichen planus pigmentosis. If there is very minimal inflammation, it is ashy dermatosis. Then necrotic epidermis and exaggerated necrotic keratinocytes, you all know it is simple. It is erythema multiforme. So now if you just see what you have to remember is, so you're seeing necrotic keratinocytes, dense, diffuse, superficial. Your diagnosis is lichen planus, you know. Then you have exaggerated higher up, then it is drug-induced lichenoid reaction with eosinophils. You have exaggerated higher up with lymphocytes, then it is GVHD. So with plasma cells, you have, then it is secondary syphilis. Secondary syphilis, dense patchy papillary dermis and histiocytes, it is lichen nitidus. So these are the diagnoses that you have to remember. Dense patchy, it is like dense patchy, then pericrine involvement, it is lichen striatus. Predominant tip of the rete, again patchy inflammation, hypertrophic lichen planus, and significant pigment incontinence when you come mild and superficial with pigment incontinence. If there is residual inflammation, it is lichen planus pigmentosus. And with minimal inflammation, it is ashy dermatosis. So if you are seeing necrotic epidermis and exaggerated necrotic keratinocytes, etc., then it is erythema multiforme. Okay, so these are your entities that commonly you encountered in lichenoid reaction, and which usually we can avoid overlaps, and you can see there can be some amount of overlap here. across tissue reaction patterns, and within the tissue horizontal or vertical overlaps can be seen. That we have to keep in mind. But more or less a broad category where you can just narrow down, this is lichenoid change, this is lichenoid reaction pattern, and this could be lichen status because I'm seeing periodic cell inflammation and papillary dermal lichenoid reaction. We are seeing plasma cells, dense diffuse deep inflammation, and so there is VDR response, then it is secondary syphilis. We are seeing lymphocytes and there is exaggerate, that is graft versus host disease. Like that you can actually deduce, and this is the algorithm. Okay, algorithm for lichenoid reaction. Hope it is of use to you.